Alrighty, also today we have Zach Thomas. He's going to be sharing a case presentation that he had to present for his residency. And hopefully we can have some good discussion and learn a little bit of something from Zach in this interesting patient case that he had. And with that, I'll give it to Zach to take it away.
Yeah, thank you, Rip. Thanks for the opportunity for me to come on and share this. I had a great time preparing for it. It was a lot of fun, something I'm super interested in. So excited to have the opportunity to present it again. And hopefully it kind of gets out and some people can ask some questions and get some thoughts moving. So without further ado, I'll get into it. So my case was on shoulder pain. I'm an 18-year-old college pitcher. So just background initially. So 18-year-old African-American male, 6'4", 260. He's a college student, left-handed pitcher. He's a one sport athlete, which could go down a whole nother rabbit hole. We won't get there right now, but he plays baseball all year round, including travel ball, off season and within season workouts. So his diagnosis, his medical diagnosis coming to me was latissimus tightness, GERD, core weakness, and scapular dyskinesis. He had no significant past medical history besides the fact that he's been dealing with this since he was 12, on and off for 6 years. No prior surgery, no medications. He has tried PT in the past a while ago. That was successful in the short term. That he noted it focused mostly on rotator cuff strengthening, but nothing that really seemed to kind of get to the root of the issue. And his chief complaint coming in was left anterior shoulder pain that was impacting his ability to throw, and that was worse on release and worse with his fastball. So his throwing background, so basically just past throwing routine. In high school travel ball, typically a game included 5 to 7 innings. Approximately 12 to 18 pitches per inning was his estimate. Pitching about 1 time a week for travel ball on Sundays, was 75, 80 pitches. And he stated that he was on no formal pitch count through any of that. Currently, he's throwing just 2 times a week, Monday and Wednesday. They're kind of in their preseason spring training phase, hoping that the season is going to start in April. His sessions include his pre-throwing warm-up and then just 23 to 25 pitches from the mound at his own self-selected intensity based on how he's feeling that day. And then there's just listed some of the pitches he throws and then what he's been clocked at as well. And then as far as his training program, he currently is doing 3 times a week, but that involves the Monday, Wednesday throwing. So it's really only lifting once a week, that with more of an emphasis on upper body strength and then squats, but no core involvement, which again is something that we'll get into further as the presentation goes on, just the role of the whole kinetic chain. And his goal is obviously to return to pitching pain-free. So yes, I'm out in California, but I'm from New York and I'm a diehard Yankees fan. So apologize, but you're gonna have to get used to the Yankee pitchers throughout. So this here is more so just for your reference. This is the phases of throwing. This could be a whole lecture in itself. But what I wanted to do is just focus specifically on these 2 phases here, from arm max external rotation to ball release, which is, as far as phases go, arm acceleration to arm deceleration. These are kind of coined as the most violent phases of the throwing phase, where typically injury can occur. So that's why I want to focus here. And then just interesting fact that moment from max external to max internal is actually in the research coined as the quickest and fastest human movement, being at about 7,300 degrees per second. So you can imagine that if things are not in alignment correctly or things are not working in sync, how that can be pretty impactful on the pitcher. So as far as examination, so I wanted to start with just cervical spine, just rule that out, make sure there was nothing going on there. So that was all clear. His range of motion was great, pain-free upon observation and standing. So he presented with downwardly rotated and protracted scapula with slight anterior tipping. And he also had some increased shoulder depression and some infraspinatus and posterior lateral deltoid atrophy, all of those being greater on the left as compared to the right. In supine, I looked at acromion to table distance, looking for, again, for that anterior tipped positioning of the scapula, pec minor length. And he did note just a couple inches difference greater on his left as compared to his right.
Before you keep going here,
Yeah,
so I guess I kind of know what I'm thinking. Of course, when it comes to ortho, I haven't even thought about ortho other than like, some soft tissue work quick here and there on some patients. I feel like I want to know what your kind of thought process was going just based on observation and kind of knowing the patient history, why you started to go forward, and kind of what your maybe initial hypotheses are. I kind of want to just see what you're thinking there, and then kind of see how, I don't know, maybe how that compares to what I was thinking, what I'm thinking anyway.
yeah, sure, exactly. So I think one thing that I'm passionate about, and then even more so now since I've gotten out here and been exposed to it even more, is just the impact on movement and movement impairments, and focusing on an individual's habitual pattern as far as movement goes, and how that can be impact the symptoms that they present with. So to me, a lot of the things that were sticking out just initially, I mean, some of the things that we expect to be common with pitchers, which I'll get into here with range of motion a little bit, wasn't as much of a surprise. But for me, his scapular positioning is what was really standing out to me, and getting him in more of optimal alignment to begin with. That's kind of where my head goes initially.
Yeah, I was just kind of thinking along the same type of route, and just thinking, he's a one sport athlete. He's been playing baseball his whole life, so he's obviously going to have muscular imbalances and strength imbalances and range of motion imbalances, biasing that left side into a pitching motion, which, being somebody who's experienced some arm issues myself, can speak firsthand to. So I think at least your observation, kind of going into observation from the history, everything seems to kind of be lining up right now.
Yep. Yeah, exactly. And I've began to really begin to see more of the importance of just pure observation on my evaluations, and looking simply just at how someone's moving. And then if I see some sort of altered movement pattern, then asking myself why, and then that's kind of what I dig into deeper during the evaluation. So moving into his range of motion. So just a couple things that I want to focus on here. So I used one of my phone actually for an inclinometer here, which has also been super helpful for shoulders and a very accurate measurement. So I just wanted to focus on external, internal, and then TRM, which is total rotational motion or total arc of motion. So for him, we saw on his left, he has slightly greater external rotation than his right, which for a pitcher, again, we expect that. That gives them that increased leverage to increase their velocity. And then kind of where, what another component that can lead to is the lack of internal rotation. So that's what is coined as GERD, glenohumeral internal rotation deficit, where they have excessive external and lack of internal. And they've found that has been correlated to increased risk of injury. So we see that his is lining up pretty consistently with that. They say greater than 20 typically in the literature, so he's kind of right on the border there. And then that total rotational motion, or the arc of motion, is the combination of your max external, max internal. And it's that full arc. And So the normative values on the right, the youth was for 17-year-olds. So he's relative, I mean, 18, he's relatively close to that. The professional level obviously is a little bit higher, at a higher intensity. So typically for total rotational motion, 180 is kind of the goal. And then depending on the level, you might be looking a little bit higher. So he actually has more on his right, his non-throwing arm. So which speaks to the difference in internal rotation for him. And then the other one here is horizontal adduction, so more of like a cross body, looking at posterior capsule, posterior cuff. And again, here, significant difference, left greater than right. And obviously we would hope that his left would even be a little bit more, since that's his throwing arm. And for this one, they say, literature says about 16 degrees different is significant. So again, he's there. So a couple things that are sticking out initially. And so that the thought of that lack of internal rotation is that with the excessive eccentric loading on the posterior cuff and capsule, that gets limited over time with throwing. So if we go, this study specifically looked at the correlation of internal rotation and the total rotation motion. And basically they looked at, it was like 122 pitchers over 3 seasons. They tracked them over the 3 seasons and then measured their range of motion and then tracked whether or not they got injured. And what they found was that with that total rotational motion deficit greater than 5 compared side to side, and then the GERD greater than 20. So with the rotational motion, 2.5 times more likely for risk of injury, and with GERD 1.9%, so almost 2% more likely. So for my case, my pitcher specifically, I mean, he has both of those. So basically you can just double it and say he's about 4 or 5% more likely as a risk, as prone for injury, purely just due to range of motion. So now getting into strength a little bit more. And then, sorry, one other point on range of motion here too, is that there was another study done that they looked at the immediate effects of throwing on range of motion loss. And what they found was, so basically they had pitchers throw 50 to 60 pitches and measured their range of motion before, after, and then 24 hours later. And just immediately after that, they found deficits in internal rotation that lasted for the 24 hours. So that's where the problem there is, when pitchers continue to throw, continue to lose, and now they're throwing in a minimal range, which that makes them more susceptible for more increased injury down the road. So we'll get into a little bit of what I did treatment wise later, but that's where staying on top of the range of motion and making sure that you're not continuing to throw in that limited range can help decrease that risk of injury. All right, so strength wise, so here I used handheld dynamometer, and his rotator cuff wasn't bad. He was actually a little bit stronger on his left as compared to his right, so that was good there, which speaks to a lot of the work that he had been doing already, and some of his past PT focusing on that, which is excellent. Where he was still lacking pretty significant was more the periscapular strengthening, so his scapular control, specifically with lower trap and mid trap. And this here is from a book called The Athlete's Shoulder by Wilk Reinold and Dr. James Andrews. And basically what it's breaking up is the MVIC of both scapular and glenohumeral muscles during the different phases of throwing. So for him, I'm going to focus on scapular a little bit and blow that up for you. And then again, specifically that mid trap, low trap. And so if we focus specifically on lower trap, which was his weakest, we see that is at its highest MVIC during arm acceleration and deceleration, which earlier I stated were the two most most violent phases of the throwing phase cycle. So not only is it his weakest muscle, but it's what's required the most for scapular stabilization during the two most violent phases during the throwing cycle. So again, just another variable for him, putting him at increased risk for this shoulder pain that he's having. Further strength testing. So I looked at serratus too, which again is a very important scapular stabilizer. And the way I did this was a resisted protraction, which is similar to that top picture there, and then more of a resisted scaption. And what I was feeling for as to strength wise was not necessarily if I could break him, but I was more so curious as to where he broke first, be it either the glenohumeral joint or at the inferior angle of the scapula. So what he did on his left consistently, he broke at the inferior angle first, meaning that his shoulder strength was fine and he could keep up with my pressure there. But he started to get a little bit of that winging from the scapula, indicating weakness at the serratus, and which was opposite. On the right, he was able to maintain that scapular positioning, but broke at the shoulder first. And then looking at lower quarter screen, so this kind of brings up the idea of the importance of, in the literature, they discuss it as the proximal kinetic chain as compared to the distal kinetic chain. Proximal kinetic chain being the lower extremity core, which generates the force and then transfers it to the distal kinetic chain, be it the arm, elbow, shoulder, that leads to ball release and velocity. So without the force generation from that proximal kinetic chain, can lead to basically throwing too much with the arm, and leads to excessive stress on shoulder and elbow, leading you again more susceptible to injury. So for him, the biggest standout on this side here was his glute med strength. So I struggled to find great normative values for someone his age, or just pitchers in general. I found more so normative values for the older population. So the takeaway here is just one, the weakness in general. I would think the glute med is a pretty strong pelvic stabilizer, so it should be pretty strong. And then for him being a lefty, his stance leg is his left. So his single limb stance during his pitching cycle is going to be on his left leg. And for him, that's his weaker leg as far as glute med goes. And there was a study done out of Auburn University that looked at the correlation between glute med strength and scapular stabilization. And they actually found a strong correlation between the two. Meaning weak glute meds led to typically weaker scapular stabilizers, which again is fitting perfectly for my patient case here as well. Again, kind of looking at the whole picture here, so thoracic mobility too, and the role that plays in throwing. So for him, left rotation, so these are both rotational measures. Left rotation, 56, right 63. So again, if we think about him being a lefty, during his coming up into single limb stance, he's going to rotate to his left, and then as he goes towards home, he's going to rotate towards his right. So couple ways that we can look at this is, one, limited in left, more in right. So he's going to have less ability to kind of rotate himself during the stance phase of the movement, and then be more likely to open up early during the stride phase. And they found that there's a pretty strong correlation between the early shoulder opening as before the foot placement in the stride phase, and increased risk for through the shoulder and elbow. So basically for the sustain for him is unfortunately I haven't had the time to do any like slow-mo videos with him to see his true mechanics yet. So this is purely just looking based at these numbers, is that it makes him more susceptible to the risk of opening up early in his stride phase, which again can lead to increased torque through the shoulder. So these two pictures kind of represent that. They're in similar phases of the throwing cycle. And the guy on the left there, he's much more, you can see his shoulders are much more closed and then much more open on the right. So that's kind of just somewhat of a visual representation as to what I mean by that early thoracic rotation and the impact that can have on the shoulder. Further lower extremity, so his squat, his depth without a half roll, he could only get to 90 before his heels started coming up off the ground. Again, which speaks to more dorsiflexion limitation, right? So with a half roll underneath his ankles, he was able to go all the way down without a problem. So not so much of a strength issue, but more of a mobility issue. And then, however, single leg squat though, on his right, he was able to go right down without a problem. But on his left, it was like asking him to do something that he's never done before. And he didn't even know how to start the movement. He was really unable to complete it, demonstrating excessive dynamic valgus and pelvic rotation with it. And again, interesting for him, I mean, he's a lefty, so his stance and plant leg is, or push off leg is his left leg. So you would expect if anything, his single limb strength and balance would be better on that side. But certainly not the case with that for sure. Any questions thus far, Rip, or we're still good?
I don't think so. I'm kind of generating my hypotheses in my head, kind of like what I'm thinking based on kind of what you're saying. But I'm just kind of letting you keep rolling with it and
All right.
see how it plays out. I'll have some thoughts at the end though.
All right, sounds good. So just some last further objective measures looking at joint mobility. He was actually a little hypermobile in all directions, both sides. So you might be thinking, like we typically think posterior inferior capsule is restricted on the throwing side, which may be not allowing as much of that internal rotation, which is certainly possibly a case, but I'll get into a couple other studies that showed that it might not just be the capsule. And then he did have some decreased lat tightness as well, and then was negative with all other special tests. So this study here looks exactly at that. So they looked at the range of motion and its comparison with glenohumeral translation. So what they found was that so they used real-time ultrasound to measure the actual translation of the humeral head, and then basically stabilize the shoulder in this machine that applied either a posterior or anterior force. And what they found was that basically between the throwing and the non-throwing side, that there really was not any difference as far as joint mobility wise. And if anything, really, it was, besides the anterior direction, it was more on the throwing side as compared to the non-throwing. So brings up the question, right, of if it's not capsule that we thought it was, then what else could it be? So that's where a lot more has been pointing to more the posterior cuff, the musculature, as well as this idea of potential humeral torsion or humeral retroversion. So that's what this is looking at here on the right. So the image on the left is more retroversion. So I like to think of it when we think of retroversion, at least me, I typically thought of the hip, but it's very similar to the shoulder. That basically that retroverted position allows them for greater external rotation, but limits their internal rotation. So just another thing to possibly keep in mind. I mean, for him, we were able to change his range of motion just within session pretty significantly. So I don't think it was any sort of bony abnormality, we wouldn't have been able to significantly change that. But something to keep in mind, especially for younger throwers, because this typically occurs mostly during that younger age when their growth plates are trying to mature, and that's all those altered forces on the humeral head that can result in that torsional force. So this was another study that looked at that specifically, and the osseous adaptations range of motion at the glenohumeral joint. So they compared throwing versus non-throwers. So this first table on the left here, they looked at the throwing group, and they found significant difference in humeral retroversion on the dominant versus non-dominant, as well as the external and internal. And then they compared between the groups of the throwers versus the non-throwers, and same thing, humeral retroversion, significant external rotation, and the total arc of motion, dominant versus non-dominant. And so interesting here, if you notice, other things that they looked at was posterior laxity and anterior laxity of the joint capsule itself, and they didn't find that to be significant. Again, pointing more towards the cuff tightness being more of the issue, or the movement pattern, rather than just the joint capsule itself. So for him, PT diagnosis, he presents with left anterior shoulder pain consistent with internal impingement due to scapular dyskinesis, periscapular weakness, GERD, and posterior cuff tightness, secondary to proximal chain weakness. So those were his numbers there, right versus left, too, for his total arc of motion. So you can see, obviously the picture is not perfect, but I just threw his numbers in there as kind of a reminder of where he's at. And then up here on the right, the force coupling at the scapula and the glenohumeral joint, is he did have excessive upper trap activation as well too, which just further promotes that shoulder elevation. And then again, he had the weakness in basically the other three, the middle trap, lower trap, and serratus. So not really working very well as a group. So prognosis wise, so given the chronicity of his pain, his prior episodes of PT, and the increased number of risk factors he has, initially I gave him fair, but I think with the correct tailored rehab and performance-based program, with patient buy-in, could easily get him to a good, because although he did have a lot of risk factors and like chronic history of this pain, a lot of his risk factors are modifiable. So things that he can take charge of and change, again, with the tailored program for him specifically. So as far as session one, intervention wise, so we did some manual therapy, just soft tissue mobilization of the posterior cuff in supine, with active internal rotation, kind of almost like a pin and stretch. And then educated him on how to do that at home with a lacrosse ball, and then just started his scapular strengthening program with some T's and Y's, and then the serratus bear hugs. Session two, I did instrument assisted and prone with and without movement. So I basically did it on kind of his lats, posterior cuff area, while he was moving from external to internal in prone. And then he progressed more of his program to add more of the proximal kinetic chain into it as well, and get the core involved with the T's and Y's on the yoga ball. And then added wall slides with external rotation, which, I mean, it's certainly a difficult movement, but for him, he was sweating bullets just after he could only do 8 reps. He couldn't even get to 10. So that was a pretty eye-opening for him. And I think that helped with our buy-in as well, as he was like, we're targeting the right places right now. So that was both, I would say, good for him and good for me in that sense, that it kind of helped with that. So then session 3, I did the instrument assisted, but I again made it more active and then added a little bit of resistance with it. So demonstrating the movement here basically with a red TheraBand, had them start in external rotation and then move into internal as I was sweeping through posterior cuff and then down into the lat. And then this session I focused a little bit more on the lower extremity and core and added some step back lunges with ball slams, and as well as staggered stance single leg squat. So I didn't go completely single leg. I gave him a little bit of stability with that other side. And again, after this session, he was gassed. So he was feeling pretty tired after this one. Again, just kind of indicating how important it was for him to not only just focus right on the shoulder, but his whole chain. So this study looked at mechanisms of shoulder range of motion deficits, and basically they were trying to propose what were possible mechanisms for lack of range of motion in baseball players. So what they found, if we just kind of focus in on cuff stiffness and internal rotation and horizontal adduction. So basically they had an instrument assisted plus self stretching and then just a self stretching group. Both groups improved, however, more significant improvement in range of motion and rotator cuff stiffness with the instrument assisted group. And there was also another study done that literally looked at, they just did 40 seconds of instrument assisted to that posterior cuff and lat region, and found immediate improvements in just 40 seconds of work. So obviously that brings up the question, right, is how long is that going to last? And yeah, that's where the education comes in for him to continue these stretches at home and the soft tissue mobilization with the targeted areas specifically individualized for him. And that's how you can kind of get the carryover from one session to another. Functional outcome measures that I gave him. So the ASES, he scored really high on that. He really only had slight trouble with throwing overhead and allowing him to do his regular sport. And his PSFS, we had so much going the first couple of days that we hadn't gotten to it, but for him it was kind of obvious what his activity limitations were. He wasn't restricted in anything besides throwing. And as far as his outcomes, impairment base, so we just at range of motion and horizontal adduction, focusing pre and post. So what kind of takeaways here is it was a slow improvement far as his initial measurements when he came in pre-treatment, but we were able to significantly change that in session. So again, for him, it was a lot of that education on keeping up with it at home and individualized to him, as well as focusing on the movement control and movement retraining of his shoulder specifically. So what's next for him? Plan moving forward, focusing on the periscapular strengthening, specifically lower trapez serratus, trying to get that force couple working more optimally at the shoulder, promoting optimal kinematics and movement patterns there, and then working on posterior cuff mobility, not necessarily capsular mobility, and then focusing on lower extremity and core strength to promote that strong and efficient proximal kinetic chain for that force development and load transfer to the distal kinetic chain, ultimately for increased velocity and decreased risk of injury. So I just wanted to, last thing here is leave you with this study that looked at a prevention program. So they were looking at throwing injuries in youth baseball players and if a prevention program could help. So what this was their program here. It was basically took 10 minutes to complete. It was 5 stretches, 2 dynamic thoracic mobility exercises, and then 2 lower extremity sort of balance movements. And what they found was just that at the 12-month follow-up, that 24 players in the intervention group still had injury, as opposed to 42 in the control group. So basically there was a 48.5% decreased risk in injury just with completing this 10-minute kind of mobilization, soft tissue work prior to throwing. So certainly something to keep in mind for throwers out there. Just take the time beforehand, take care of your body, so that you can ultimately help reduce the risk of injury. So I'm currently still seeing this guy right now, so I don't have any final kind of outcomes. But what I can tell you is that we've spaced out his sessions pretty well, and I've created a pretty extensive home program for him, including breaking it down by days as more of like a training program with mobility work mixed in. And the last time I saw him, he's basically throwing pain-free at this point, and hasn't really been limited at all. So we're definitely winding down. But I think what we've done thus far has been helpful and successful for him. So that's everything I got for you. So fire away, Rip.
All right. No, I think it all kind of flows and makes sense in my head. Obviously, I don't treat the ortho population right now, and haven't treated a lot of baseball players particularly, but from my personal experience and just kind of understanding human movement, pretty much the parascapular muscles that you were talking about and those external rotators particularly are kind of the most stressed muscles throughout the throwing process, especially when they're compared to their size. And if you have deficits in other areas that force you to translate forces onto those muscles, you're going to end up with issues. I know from personal experience, when I had Tommy John surgery, I came back afterwards, and because I was tentative to load the elbow, I started loading the shoulder extra when I was throwing. And because I hadn't been throwing, those muscles weren't in throwing shape per se. And I developed some dyskinesias or dyskinesis and tons of other shoulder issues, SIS, all that kind of stuff. And pretty much had to do a training program every day before I threw. And even now, like if I go play catch, like my arm hurts the next 4 days. If I don't do my empty cans, my ITYs, and general core and lower extremity warm up, my arm hurts, and it's really frustrating. But I think it's just, especially throwing is such a dynamic movement that involves so many body systems and total body control and effort, that any deficit within any part of the chain is going to show up in those parascapular or paraglenohumeral muscles.
Yep. Yeah, and I think you bring up a great point too that I didn't mention. It's just the size of these muscles. So just how much we're asking of them during throwing, and then them relative size to more of the global muscles, like the lats and the pecs and everything, is pretty significant. Yeah, so we're asking them to do all of this and have the highest MVIC and everything during the most violent phases. However, they're the most smallest muscles that we could do for that. So I think that demonstrates the importance of taking care of them and optimizing the movement pattern in order to set them up for the greatest success and not result in any overactivation.
Yeah. I mean, it seems like you did a great job. He's getting better, so that's all that really matters. And so, I mean, good job with the case. I liked all the research that you kind of brought into it. And a lot of those prognostic values and kind of just understanding loading throughout the specific movements, I think is really important, because then you kind of can guide your exam and know what you're trying to look for and trying to find with those patients that come in. And our patients with neuro conditions, it's kind of what neurosystems are intact and what's not intact, and then what can I change or hope to see change in through intervention, and what am I going to kind of have to compensate for and work around.
Yep.
So I think, yeah, great job. Thanks for sharing, and hopefully, some clinicians out there can get something out of it and learn something new.
Yeah, thank you. Thanks again for the opportunity for letting me do it for another round. It was fun.
Sure thing. All right, Zach, we'll talk to you soon.
All right, see ya.